Good morning, I'm Peter Barnes from Imperial College, and I'm going to talk about inhaled therapies for COPD. These are my potential conflicts of interest, which are not very relevant to this presentation. I want to start with the enormous burden of COPD. At the moment, around 350 million patients are affected by COPD throughout the world, and it affects around 10% of people over the age of 45. Male and female prevalence is similar in Western countries, which reflects the equal prevalence of cigarette smoking. This disease is still underdiagnosed, and over half the cases are probably not recognized. It has a high morbidity, ranked number 5 amongst all diseases, and is a leading cause of emergency hospital admission. It has a high mortality and currently the 3rd commonest cause of death in the world, and is also very costly, over $30 billion a year in the USA, and predicted to cost around $5 trillion globally by 2030. COPD is rising in prevalence, especially in developing countries. That's because more women are smoking, but more important is that the populations are aging throughout the world, and COPD is associated with poverty, which is increasing. There are major unmet therapeutic needs in COPD. We have no safe and effective anti-inflammatory treatment, and that's partly because COPD inflammation is not steroid sensitive. We don't have any treatments that significantly reduce disease progression or mortality, and we're still not able to prevent all exacerbations in COPD patients. So we do need new treatments in the future. If we look at the pathology of COPD on the right, this is a disease that affects the peripheral lung, small airways and lung parenchyma. And you can see that a small airway from a COPD patient is narrowed compared with the normal airway on the left. And the airway wall is greatly thickened. This is as a result of inflammation, which leads to fibrosis, which results in fixed airway obstruction. In addition, you can see that the alveolar attachments are disrupted in COPD, and this is a consequence of emphysema. These pathological changes have important functional effects. In normal people, on expiration, the airways narrow, but they don't close because the alveolar attachments contain elastin fibers. However, in COPD patients, the airway is already narrowed, and the disrupted alveolar attachments mean that on expiration, the airway may close completely. This traps air in the lung, and you can measure this with increased lung volumes. And this air trapping increases on exercise. This is known as dynamic hyperinflation, leading to shortness of breath on exertion and reduced exercise tolerance, which are the major symptoms of COPD. But we can reduce these symptoms by long-acting inhaled bronchodilators, which relax small airways and therefore reduce air trapping. The 2 major classes of long-acting bronchodilator are long-acting muscarinic antagonists or anticholinergics such as tiotropium, and long-acting beta agonists such as salmeterol. This shows the effect of a LAMA on lung volumes. You can see that there's an increase in FEV1, which we expect to see with a bronchodilator, but this is a small response in COPD. However, the reduction in functional residual capacity, the resting lung volume, is reduced to a much greater extent, reflecting the reduction in air trapping with tiotropium. We now have several different LAMAs, and glycopyrrolate is an old drug, but it's been shown to have a similar bronchodilator effect to tiotropium, lasting over a 24-hour period, and so suitable for once daily dosing. There are other LAMAs, umeclidinium and revifenacin, which are also once daily, and aclidinium, which is given twice daily. All of these LAMAs give a sustained improvement in FEV1. They reduce air trapping, which reduces symptoms and improves the quality of life. And these drugs also reduce exacerbations. The way that anticholinergics work in COPD is to inhibit intrinsic cholinergic tone due to the tonic release of acetylcholine from vagus nerve endings. This is something that we see in normal people. And in COPD, the cholinergic tone may be similar, but because the airway is structurally narrowed, the effect of this tone on airway resistance is magnified because of the relationship between resistance and the inverse of the fourth power of the radius. This means that when we block cholinergic tone with a LAMA, that you get a greater reduction of resistance in COPD patients than in normal patients. What has been found is that LABAs have a similar bronchodilator effect to LAMAs. And this is very different from asthma, where LABAs have a much greater effect because they act as functional antagonists and will inhibit all of the bronchoconstrictor mediators that are contributing to the airway narrowing in asthma. But if we see LAMA and LABA have similar effects, it means that cholinergic tone is likely to be the only reversible mechanism in COPD, in marked contrast to asthma. So it was found that LAMAs reduced exacerbations in COPD patients. And in this study, tiotropium was compared with the LABA salmeterol and was actually more effective in reducing exacerbations, particularly in the more severe patients. This difference may, however, not be due to any difference in the mechanism of action of these drugs, but due to the duration of action. So the longer the duration of action, the greater benefit you have in terms of reducing symptoms and preventing exacerbations. And this can be seen with the once daily LABA indicatorol, which you can see has a greater effect on symptoms than the twice daily salmeterol. And this is also reflected by an improved quality of life with indicatorol compared with salmeterol. So once daily bronchodilators are better than twice daily and better than 4 times daily, irrespective of the class. So here is indicatorol giving a 24-hour bronchodilator effect. And in this study, they looked at a higher dose of indicatorol than we normally use in clinical practice, but it gave no further bronchodilation, showing that you've reached the maximal bronchodilator effect with indicatorol. So it's surprising that when you add the LAMA glycopyrrolate in this combination inhaler, that you can actually see additional bronchodilation, which is approximately double what you see with indicatorol alone. And this additive bronchodilator effect has actually been seen in long-term studies. So here you can see that the combination of indicatorol glycopyrrolate has a greater effect on FEV1 over time than using the single agents or tiotropium alone. And this has led to the development of LABA-LAMA fixed dose combination inhalers, which give the optimal bronchodilator response in COPD. There are 3 once daily combinations: indacaterol glycopyrrolate, olodaterol tiotropium, and vilanterol umeclidinium, which we consider to be equivalent. There are also twice daily combinations, all of which contain formoterol combined with tiotropium, aclidinium, or glycopyrrolate. A third type of combination is a dual acting drug that has a beta agonist at one end and a LAMA at the other end that are linked together, and several MABAs have been developed. But the problem is that it's very difficult to balance the beta agonist and the anticholinergic activities. So these have turned out not to be as useful as the fixed dose combinations. All of these treatments reduce air trapping, and this leads to reduced symptoms, improved quality of life, reduced exacerbations, and you also can see improvement in cardiac function due to the reduction in air trapping. All of these drugs are well tolerated. If we now go to the gold management strategy for COPD, as you know, patients are divided into 4 groups according to symptoms and exacerbations. By far the most important groups are B and D, and in both of these groups the patients have symptoms that need to be treated, and in group D patients, which is about 30% of patients, they have exacerbations, defined as 2 or more exacerbations or 1 exacerbation that may lead to hospital admission. And as you can see, long-acting bronchodilators are the mainstay of treatment for group B and D. But in the group D patients, you also have a choice of LABA-LAMA combination or ICS-LABA combination. So that brings me to the role of inhaled steroids in COPD. This is a meta-analysis of studies that compared inhaled steroids with placebo in COPD. And the studies showed that there was a reduction of around 20% in exacerbations when inhaled steroids were added. So studies have consistently shown a reduction in exacerbations of 15 to 20%, but little improvement in FEV1 symptoms or quality of life, no effect on mortality, and no effect on disease progression. So the main indication for using inhaled steroids would be to reduce exacerbations. In this study, ICS-LABA was compared with LABA-LAMA combination. And what you can see is that, in fact, the LABA-LAMA combination was more effective in reducing exacerbations. And this was irrespective of the sex, race, smoking status, disease severity, or previous treatment with inhaled steroids. We now know that measuring blood eosinophils before starting inhaled steroids is a very useful way of predicting which patients will show the best response to inhaled steroids. And in this post hoc analysis of 3 studies comparing the LABA alone, which is formoterol, with the ICS-LABA combination budesonide formoterol, what you can see is that as blood eosinophils increase, then exacerbations are seen more frequently. But the effect of adding the steroid to the formoterol gets greater compared with the formoterol alone as blood eosinophil counts increase. So we normally take a blood eosinophil count of about 300, which is the upper normal level as the cutoff point to decide whether we should use inhaled steroids to reduce exacerbations in COPD. But inhaled steroids do have side effects, and particularly in COPD, because we tend to use maximal doses, because this is not a steroid responsive disease. There are local side effects, particularly hoarseness of the voice, but the systemic effects that may be seen after long-term use include osteoporosis and fractures, particularly because in COPD there's an increased risk of osteoporosis, there's a greater risk of cataracts, and comorbidities, particularly type 2 diabetes, may be more frequent or worsened by adding an inhaled steroid. And then finally, there's an increased risk of lung infection, and particularly of developing pneumonia. This is seen in the large TORCH study, which was conducted over 3 years. And what you can see is that there's a progressive increase in developing pneumonia with the steroid treatments, which was either fluticasone propionate alone or in combination with salmeterol. And if you look at the number of patients needed to prevent one exacerbation, it's 44, whereas the number needed to treat to induce one pneumonia is only 16. So it's not a good cost safety relationship here. And this is confirmed in community studies of COPD patients who are prescribed inhaled steroids, which also show this increased risk of pneumonia. This is dose-related and is also related to the choice of inhaled steroid. So is seen more frequently with fluticasone propionate, which tends to be retained longer in the lung than budesonide. And if you look at the risk of pneumonia in relation to blood eosinophils, you can see that pneumonia is more frequently seen in those patients with low blood eosinophils, which is another reason to restrict the use of inhaled steroids to the patients with higher blood eosinophils. So many patients at the moment are treated with high-dose inhaled steroids, and for many patients, the inhaled steroids may be causing more harm than good, and so should be slowly withdrawn. And this is a study in patients with severe COPD that had a history of exacerbations, all of whom were treated with tiotropium, LABA, and an inhaled steroid. And you can see that when the steroid was discontinued, that there was no evidence for increased exacerbations. This is also seen in another study of less severe patients, and this is a study where they switch patients from triple treatment to LABA-LAMA therapy. In other words, the steroid was withdrawn. And what you can see is that the patients with lower blood eosinophils showed no evidence for increased exacerbations, but increased exacerbations were seen when blood eosinophils were greater than 300 cells per microliter. So it means that this is an important consideration in deciding which patients should be treated with inhaled steroids. But when patients are selected for inhaled steroid treatment, the most convenient way of giving this is as a triple fixed dose combination with ICS-LABA and LAMA in the same inhaler. And this demonstrates that such a triple inhaler gives you a greater bronchodilator effect than ICS-LABA, which is not surprising, and also shows less exacerbations. There are now 3 triple inhalers available for COPD patients. two of them are given once daily and one is given twice daily, and a fourth is in development. And there are two large studies of triple combination inhalers in COPD. The first is the IMPACT study. And you can see in this study that the patients treated with the triple inhaler had less exacerbations. And again, this effect was greater in the people with higher blood eosinophils. However, this study is somewhat difficult to interpret because the difference was only seen in the first month, and then the lines are parallel, and the majority of patients were actually on inhaled steroids at the start of the study and were withdrawn from the steroids when they were switched to the LABA-LAMA group. In this study, as in other large studies, you could see increased risk of pneumonia in the patients treated with inhaled steroids. The second study looked at a twice daily triple combination, and here you can see similar results. They looked at two different doses that were quite similar for the triple inhaler with two different doses of budesonide, and you can see there were less exacerbations with the triple than with the LABA-LAMA or the ICS-LABA combinations. So this is giving very similar results. If you look at these two studies together, what you can see is that there may be a reduction in cardiovascular mortality with the steroid containing triple inhalers compared with the dual inhalers. And this is seen in both of these large studies. So this is something that's not yet certain because the number of people dying is so small, but it's encouraging that maybe larger studies might show a reduction in mortality. I want to end with future of inhaled therapies for COPD. So the mainstay of current treatment for COPD are inhaled long-acting drugs, as I discussed. But there are new classes of drug in development. We already have an oral phosphodiesterase 4 inhibitor, roflumilast, available for treating severe COPD, but it has unpleasant side effects, so is not popular with patients. And this has led to the development of several inhaled PDE4 inhibitors, but most of these failed on efficacy grounds, although they had no side effects. There is one inhaled PDE4 inhibitor which does seem to have some effects in COPD in reducing sputum inflammation, but is not seen to have much efficacy in terms of reducing exacerbations. A PDE3/4 inhibitor called ensifentrine is in development, and when this drug is given by nebulizer or dry powder inhaler, it shows a bronchodilator effect in COPD and asthma, and this is due to inhibition of PDE3. The drug also inhibits PDE4, which may have anti-inflammatory effects, but is 3,000 times less potent at inhibiting PDE4 than PDE3. So the anti-inflammatory effects are not convincing for this combination. P38 MAP kinase is activated in COPD, but inhibiting it with oral inhibitors has not been shown to have any significant clinical efficacy, and these drugs tend to have a lot of side effects, which again has led to the development of inhaled P38 inhibitors, but so far these have failed in terms of efficacy. PI3 kinase gamma delta inhibitors are anti-inflammatory in COPD in vitro and reverse steroid resistance. They've now been tested in COPD, but so far there are no indications that they have significant clinical efficacy. Pan-JAK inhibitors are theoretically good treatments for COPD because they have anti-inflammatory effects in vitro, and several of these drugs are now in development for inhalation, but we haven't seen any reports of efficacy so far. And lastly, people have been looking at inhaled cytokine inhibitors. So far, cytokine inhibitors, particularly biologics, have not been shown to be effective in COPD. Inhaled antibodies, therefore, would have no particular benefit, but inhaled anticalins, which inhibit cytokines, may have potential in the future if we can find a key inflammatory cytokine to inhibit in COPD. So in conclusion, inhaled long-acting bronchodilators are the most effective treatments for COPD, and LABA-LAMA combinations have additive effects, which are the most effective treatments that we currently have for COPD. Inhaled steroids reduce exacerbations and seem to be effective in patients with higher blood eosinophils. And in these patients, triple inhalers may be convenient. There are some new inhaled therapies in development, but so far none of these have shown efficacy. So inhaled therapies are likely to be the major therapeutic approach for COPD in the future. And what is needed is to target the inhaled therapy more effectively to peripheral airways, and in the future to the lung parenchyma. Thank you very much for your attention.